I am Sophia Surguladze. I'm a US CDC contractor through the Taskforce for Global Health. I'm from Georgia, and I'm a scientific coordinator for all viral hepatitis-related activities in Georgia. And today I'm going to be presenting part of the analysis that we did, where we characterized adults who remain to be screened and those lost to follow-up from the HCV elimination in Georgia. And I have no conflict of interest to declare. So I'll go through the background. Some of you already know, some of you don't, but Georgia started its national elimination program in 2015, and it aimed to diagnose 90% of those infected and treat 95% of those who are diagnosed with chronic HCV. And at the beginning of the elimination program in 2015, Georgia performed a nationally representative survey where we found that around 5% of our population had HCV infection, chronic HCV infection. And then 6 years into the elimination program in 2021, we repeated this survey, and we found that prevalence was down to 1.8%, which corresponds to a 67% decrease in prevalence over 6 years. In addition to this, by August of this year, over 85% of our adult population was screened for HCV. About 87% of those who were anti-HCV reactive were tested for viremia, and around 85% of those with current infection initiated treatment. And of course, this is great progress, and we're very proud of this, but we're definitely nearing the end of our elimination journey. And with this comes the last push, and which gives the biggest resistance in terms of reaching elimination. And one of the biggest challenges that we found working on this was loss to follow-up. So engaging people in screening and then also linking people to care through the HCV cascade. So what we decided to do was to look at three groups of people. So the first are those left to be screened for anti-HCV, which is a very challenging population this far into the elimination program, given that they've had 8 years to be screened, and they haven't. So this is a population that we wanted to look at. Also, we decided to look at those individuals who are anti-HCV reactive, so they've been screened positive for HCV, but they never showed up for viremia testing, and they never got confirmed. And then the final group of people are those with chronic HCV infection, so people who went to confirmation testing, found out that they have chronic HCV, and then they never initiated treatment. And so this analysis, with this analysis, we aim to estimate these populations, calculate the number of individuals in each group, and to also characterize them based on different demographic characteristics, to understand where these people are and who these people are and how we can better reach them. So the methodology for this was quite complicated, so I tried to condense it down into one slide. One thing that you have to know is that every Georgian has a unique 11-digit ID, which makes tracking very easy. And so how we found those left to be screened was that we looked at the HCV screening registry, we looked at those IDs, and then we compared it to the 2023 population data from Geostat, which is a nationally representative statistics office in Georgia. And then whatever personal IDs didn't appear in the HCV screening registry, we assumed these people, oh well, we know that these individuals have not been screened. In terms of finding those lost to follow-up from viremia testing and treatment, this was more easy given that we have these HCV screening and treatment databases, and we know that we know when people are lost from the cascade and who these people are. We decided to exclude children for this particular analysis, even though children are screened. We also excluded people with documented death dates and vital statistics so that it didn't artificially enlarge our numbers. And then we also exclude those screened at harm reduction sites who were using anonymous 15-digit codes because there was no way that we could track them, although not everyone in harm reduction centers uses these codes. So the general results that we found is that the adult population left to be screened is around 650,000 individuals, which doesn't look like it's that big of a number. However, this is the hardest population to treat, given that we've already screened around 2.8 million people. But these are the people that are the hardest to find. In terms of those who have never received viremia testing, even though they're screening positive, this number was around 20,000 individuals. And those who had never initiated treatment despite knowing that they have chronic HCV, that number was around 14,000 individuals. So I'm going to go into just a little bit more detail per group. So the first is going to be the adult population left to be screened. Here we can look at the sex distribution of this population, which is pretty even for males and females, with males just being slightly more represented in this population. Now, in terms of the age and sex distribution, here we can see that in males, like the youngest males, those aged 18 to 30, had the highest proportion of not being screened. However, this does come with one caveat that people are being added into this group as every year passes, so we can more or less understand why we have such a high number here. For females, this was more or less evenly distributed among those aged 50 to 70 who haven't been screened yet. We're also going to look at the adults who are not tested for HCV viremia. And here the sex distribution is a little bit different. So we can see that males far surpass the females in terms of not being confirmed for HCV, despite having a positive HCV screening test. And the age and sex distribution actually highlights a problem that we're going to see going forward in the slides, and that is the male problem population, something that Sonia also pointed out in her presentation. So males aged 40 to around 60 years old just are a huge percentage, well, not a huge percentage, but a comparatively big percentage of the individuals who have not received viremia testing by age and sex. And for females, this is a relatively stable number from 40 to 70 years old. One additional thing that we wanted to look at for this group was the proportion of those adults who have not received viremia testing by the venue of their latest screening. So where are people being screened, and does that somehow contribute to them not getting their viremia test? And here we found that prisoners were pretty high up in terms of that percentage, but also inpatients. So people, just for your information, everyone in Georgia who is hospitalized overnight is going to get screened for HCV, which is a part of the hepatitis C elimination program. And here we can see that this is also a problem in the sense that a lot of people get screened in inpatient settings. They screen positive, but no one tells them, and they leave the hospital and they have no idea. So this is a problem that has to be highlighted. And then finally, adults with chronic HCV who have not initiated treatment. Here, the proportion by sex is also skewed more towards males, with over 2/3 of that population being male. And in terms of the age and sex distribution, here we can see the same thing. So males aged 40 to 60 are those who are not initiating treatment despite having chronic HCV. And in females, this number is highest in those older than 80 years old. However, we have to understand that, at that age, people have other health problems, they have other priorities, so they might not find it the highest on their priority list to treat their HCV. And I'm just going to go through some conclusions that we have that I already highlighted. So younger adults, especially those aged 18 to 30, had the largest proportion of not being screened for anti-HCV, but I explained why this may be. Also, men, especially those aged 40 to 60, and people in prisons and inpatients had the lowest proportion of anti-HCV positive persons being tested for viremia. And in terms of initiating treatment, we had highest drop-off for men aged 40 to 60 and also older women. And there's some steps that have been taken, some steps that we are planning on taking. The first is the Linkage to Care program that has been running for a few years now. There's actually a poster on it in the other hall over there, where we are actively finding people who have been dropped off from the HCV care cascade, but also finding the people who have not been screened, trying to reach them via text messages, by calling them several times. We also have the HCV self-testing journey that we've been on that Sanyal already presented, just trying to test out what works in our population and who will benefit from what sort of screening. Also, the involvement, we're planning to involve the primary healthcare sector more heavily because they have more capability to reach people who are in their general vicinity and to follow up with them. And we're also thinking about installing patient navigators in inpatient settings so that no one is actually leaving the hospital with a positive screening test who will never be confirmed. And then I want to say a quick thank you to all of my co-authors, and also I want to acknowledge all those organizations that play such a huge part in hepatitis C elimination program in Georgia. Thank you.